Attendees, kindly be seated. We'll begin the program shortly. Hello. Attendees, kindly be seated. We'll begin the program shortly.
Yes, I can hear now. Can you hear me?
Yes, ma'am. I can hear you.
Okay, great. So it's done then?
Yes, ma'am. Just try to share your screen if you are facing any issues.
This is a second announcement regarding competition. Hope all of you are excited about it. So all you have to do is take the video about what's happening in IDC, make a reel out of it, and share it with SLP Quest. That is SQUEST. And you should be using the hashtags Habibi, we are in Goa, and it's safe time swallow. Last date is tomorrow, which is March 11th, 10 a.m. So I request all the participants to show up your enthusiasm to make up the reel and submit it on time, which is tomorrow, March 11th, 10 a.m. Today, we'd be having a banquet dinner at 7 p.m. Hope all of you are ready for that as well. So we'll finish our talks as early as possible so that all of you can get dressed well and attend the banquet party. So here we begin, which is oral paper presentation. So first and foremost, I would like to welcome our judges, Ms. Sonal Chaitnis, Associate Professor at Bharatiya Vidyapeeth, Pune. She'll be joining with us online. Mr. Bhaskar De, Consultant Speech Language Pathologist at AMRA Hospital, Kolkata. Mr. Somnath Mukherjee, Senior Speech Language Pathologist, Apollo Hospital, Kolkata. I welcome Mr. Bhaskar De and Mr. Somnath Mukherjee to take over your seats. Please, sir. Thank you, sir. So can we join our hands to welcome all our participants? Kindly I request Bhaskar sir to read out the rules for the presentation, following which your names would be called out based on the serial order.
Hello, good afternoon. First of all, I look to congratulate for all the participants who are presenting today. There are a few rules which I want to discuss. The evaluation will be done on the few things, 4 points mostly. First of all, we'll look into the clinical utility of the study, then the strength of methodology, then the clarity of the presentation, and lastly, justifying or justification of the study findings with support to literature. And one thing I want to mention, as because the platform presentations we have extended the timings. We have extended it to 8 to 10 minutes, so you're free to present. And we will have a discussion for about 2 to 4 minutes. Thank you.
So here I call upon the first contestant, Ms. Gopalakrit Jayapratha.
Good afternoon, all. It's a pleasure to be here. Hi, Bhaskar. Yes.
Can you hear me? Oh. Ah.
Yeah, I want to clarify. We have got 6 minutes first warning for the presentation to end. 8 minutes, it will be the final. The presenter should stop, and then we'll have concrete of 2 minutes for the discussion.
Okay.
Do you get it?
6.
6 minutes, we will be giving you the first warning. There will be a sound buzzer. 8 minutes, the second buzzer will come when you have to completely finish. Then you've got 2 minutes to finish off with your presentation with the question answers. Okay.
Thank you. I'll just check once. Oh, you're doing. It's changing. Okay, so I have to. Oh, this time. Oh, okay. 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 Good afternoon, one and all.
The study topic of my study is feeding skills among preterm infants at term equivalent age, a caregiver report, and observation of feeding. So neurological maturation and extrauterine experiences contribute to development of preterm infants at term equivalent age. There have been studies which explored feeding skills and other behaviors of preterm infants at term age, and it showed that poor neurobiological outcomes have been observed, which result majorly in motor domains. And there have very few studies which has observed that preterm infants at term equivalent age exhibit feeding behaviors, differences observed in feeding behaviors. And those studies are very minimal, and there are only two studies. That is, and one study was done using instrumental measurements of sucking. And the most recent study by Pineda et al. 2020, it observed that infants had feeding difficulties at term, preterm infants had feeding difficulties at term equivalent age, but this had a very small sample size. And the assessment range of this study was very wide, which was between 35 to 40 weeks of age. So there was a lacunae in this area. Hence, I'm doing this study to understand the difference in feeding skills of preterm infants, which provides a way to assess the central nervous system integrity and consider opportunities for early intervention. So the aim of my study is to compare feeding performance of preterm infants and term infants at term equivalent age, that is between 38 to 40 weeks of age. So my study was done in a tertiary care hospital, and I had included 170 infants, where these infants were categorized into 3 age groups that based on their gestational age, that is less than 34 weeks, very and moderate preterm, and late preterm and term infants. These infants were assessed between 38 to 40 weeks of age. During their assessment, their mode of feeding was observed, and I had done a comprehensive assessment where parents were requested to feed the baby in front of the SLP, who observed their skills and rated their feeding was asked to breastfeed the infant irrespective of the current mode of feeding. So on breastfeeding assessment, the SLP scored them based on Bristol breastfeeding assessment tool and a preterm infant breastfeeding scores. Later, these parents were given a parent report questionnaire. The parents had to fill a self-report tool based on their feeding experiences with their infants. This was done using a neonatal eating assessment tool on breastfeeding. So all of these infants, moving on to results, which shows that all of these infants did not have a significant difference across their age group during assessment. So irrespective of being very preterm, moderate preterm, late, all of them were assessed at around 40 weeks. So on looking into the results of mode of feeding, it was found that minimal number of infants were direct breastfeeding. Majority of them were on combination of direct breastfeeding plus Paladai feeding and in very and modern infants, whereas late preterm and term infant were significantly different from them, and majority of those infants were on direct breastfeeding only. And there was significant difference by seen by doing a chi-square analysis. Sorry. So on seeing the assessment, standard assessment protocol, it was seen that a very preterm and moderate preterm infants scored significantly low, had significantly lower scores on the EFS and NEO-EAT tools in comparison with the late preterm and the term infants. On assessment on NeoEat tool, which I had used for standard feeding assessment protocol. So classification of NeoEat tool results show that almost all the infants in late preterm and term in a group had normal feeding development, whereas the infants, around 50% of the infants in the very and moderate preterm group had feeding challenges and questionable feeding behaviors. So the breastfeeding tools show that the scores of infants in very preterm and moderate preterm had a very lower score in comparison with late preterm and term infants. All the late preterm infants had similar behaviors that of term infants. Parental reports showed that parents in the very preterm and late preterm, moderate preterm group had major concern on the infant's feeding behavior than the other two groups. So moving on to discussion. Differences observed in their feeding behavior on comparison with late preterm and term infants, which was similar to a few of the behaviors which they exhibited was poor arousal state, inadequate suction, continued difficulty during breathing difficulty during feeding. I believe that ours is one of the first study to use SLP observation as well as a parent report with a narrow narrow window of assessment. And I feel that in-depth observation is required for early identification of any disrupted feeding behaviors at term equivalent age. And parent report provides support to the SLP's assessment. Implications of the study is that there is a need for continued monitoring of feeding among preterm infants even after oral feeding skills are established, and feeding difficulties can be recognized as continued negative experiences would hamper feeding development. This is in line with the synaptic theory of infant development, and early intervention is required to promote the feeding skills at term equivalent age or in NICU, which needs earlier evaluation. And a parent report tool can be administered. Tools which is similarly used in my study can be used to administer red flag infants who need detailed assessment by an SLP. Thank you.
Thank you for your
Yes.
presentation. Any questions?
What is the study time? Like you have studied 170 infants in how many months or years?
I had taken around 1 year to finish the study, sir.
Okay. So out of them, how many of them has comorbid like laryngomalacia?
I had excluded all the infants with congenital abnormalities and genetic malformations.
These are all preterm but normal baby.
Preterm with minimal underlying comorbidities other than the congenital.
There is no HRR there. No high risk registers was there.
Sorry, sir.
HRR.
High risk HRR was there. Mild respiratory distress, infants with mild respiratory distress syndrome. Actually, can I show the infants who had intrauterine growth retardation, mild pulmonary dysplasia, infants who had respiratory distress syndrome, which was only mild and minimal. I didn't include infants with severe issues.
So referral was the doctors or it is referred by who?
These are referred by neonatologists. I did the assessment in the in Ramchandra Hospital. We have an NICU unit and an outpatient unit. So infants were seen when they had been discharged and they came back for immunization or other visits.
So you have been assessed in the NICU or after the discharge?
After the discharge. I assess these infants after the discharge.
But mostly the protocol says whenever the patient is there in the NICU, if he or she was on the NG tube, the patient should be referred to the SLP, and not only the observation report, the SLP should start the management immediately.
Yes.
Initially, we start with the suck, swallow, breathe coordinations, and we train the nurse. And the amount of feed should be given, it should be decided by the neonatologist and the SLPs.
Yes, sir.
So all the assessment has been done after the discharge from the hospitals, and not a single patient was there on NG.
No, sir. None of them were on NG.
So that means it is very clearly.
Ah.
So patients are coming, what they were trying to develop a tool, but in terms of treatment efficacy, the role of FSCP is less in this case.
So, sir, actually, I wanted to observe the skills of these infants at term age. We know these in, yeah.
I understood that,
Uh-huh.
but
Uh.
whenever we go for a evidence-based practice,
Mm.
on that case, the role of SLP is very clear. We try to give inputs to the parents, how they can feed better.
Yeah.
So in this case, only the patient is on the feeding and they don't have any NG.
Yes, sir. They don't have NG. So actually, this was, I am I'm a full-time PhD scholar. My main study is on effect of oromotor intervention on preterm infants
No,
in the
that
hospital.
is understood. But
no,
basically,
yeah.
we are clinicians, we always look for the treatment protocol.
Yeah, and as you said, sir, after the study, I also felt that the care given in the NICU needs to be improved because it was
Refer to the SLP. That protocol has been followed
Yeah,
in
yeah.
all Apollo.
Yeah.
Okay, thank you.
Thank you.
Good suggestion. But don't do it after the 16th.
Call upon the next contestant, who's Mr. Harish.
Pointer this side, right?
Hello? Yeah. Is he presenting? Because the presentation was someone else's, I think. Or else. No. Where is the second presenter? Not good. Not yeah.
Sorry for the confusion. We'll be going in the serial order that's been already provided. So your team would be going third. Mr. Harish, your team would be going third. So now I call upon Ms. Ambika.
So good afternoon all. I, Kamalika Sarkar from AYGNI SHD, am presenting our study on transadaptation of reflux symptom index in Bangla. So as we know that reflux is a return of the fluid, that is the backflow of the gastric contents into the upper aerodigestive tract leading to the throat symptoms. So LPR is a gastroesophageal reflux disease that affects the pharynx and the larynx. Several studies demonstrated that LPR is not an extension of the lower esophageal refluxed into the upper aerodigestive tract. So nowadays there is a lot of changes in our food habits, and there is the sedentary lifestyle that has led to the increase of number of patients with reflux. So the world over prevalence rate of LPRD ranges from 5 to 30%. Now coming to the RSI is a 9-item questionnaire that has previously been evaluated by Belavsky. The prevalence of LPRD in Indian population as assessed by RSI score that is greater than 13 was 11%. In India, RSI till now is only adopted in Hindi and Kannada. So the common symptoms of LPR like dysphonia, swallowing difficulty, cough, frequent throat clearing, sore throat, thick mucus in throat, feeling lump in the throat. Now coming to the need of the study. So according to the census of India, 8.03% of the people of India speak Bangla. That Bangla, the second most spoken language. And other than that, there is Bangladesh, whose national language is as well Bangla. So a large population of Bangla-speaking people is having the risk of LPRD. So there is a lack of the standardized tool, and so there is a need of the present study, that is to develop the Bangla version of RSI and to evaluate its validity in Bangla-speaking population with suspected LPR. Now, the objectives of the study to adopt RSI Bangla for assessing patients with LPR. And the next is to establish reliability of the RSI. In methodology, we have taken 60 participants, and these participants were divided into two groups. One group has 30 participants with LPRD, that is group 2, and group 1 has 30 participants without LPRD. For criteria, there is the inclusion criteria that includes the age limit between 19 to 60 years who were able to speak and read Bangla and that did not have any voice problem on Grabo scale. For exclusion criteria, tobacco smoking or alcohol addiction, pregnancy, neurological diseases, upper respiratory tract infection, swallowing disorders, current use of antacid, previous history of neck trauma, etc. were being excluded. Now coming to the procedure, we have taken this study and divided into 4 phases. The first phase has the translation of English RSI into Bangla language following Breslin methodology of cross-cultural translation. Phase 2 has the validation of this scale, and phase 3 has the pilot study that was undertaken in which the scale was administered on pre-diagnosed LPRD patients. And for the 4th phase, we have data collection validated by correlating patients on BRSI with the diagnosis of LPRD by laryngologist or gastroenterologist. Now coming to the results, descriptive statistic analysis was done for group 1 and 2. We have maximum, the mean, the standard deviation, median, mean rank. Data was analyzed using Shapiro-Wilk test for normal distribution. It was found to be significantly deviating from the normal distribution. And then what we did was we have taken the non-parametric Mann-Whitney U test was done to analyze difference in the RSI total group between total scores between the groups. So this difference in values statistically significant. The p-value for the group was 0, which was statistically significant. Now, coming to the retest reliability, this was obtained using Cronbach's alpha coefficient by comparing baseline and retest scores. The Cronbach's alpha value is 0.92, more than 0.8, suggestive of high reliability. This result indicates that BRSI is a reliable tool. So the discussion says that most common symptom of LPR reported by subjects was heartburn, followed by clearing of throat and excess throat mucus. LPR can be present with dysphagia, commonly felt in the upper chest and neck, usually assumed to be due to the posterior laryngeal edema caused by the reflex-induced tissue irritation. The large population who speaks Bangla has growing risk of LPRD. This study hence provides an effective questionnaire for Bangla-speaking individuals, as well as a valid and reliable tool for documenting symptom improvement in patients undergoing treatment for LPR. Now, finally, the conclusion says that the findings indicate that the developed RSI Bangla is a reliable and valid tool for LPR. RSI is a non-invasive tool. Unlike endoscopy, it is easy to administer and effectively diagnose LPRD in native Bangla speakers. So this is the developed RSI in Bangla. These are my references. Now the topic is open for discussion.
Nice, very good and fast presentation. We have a few questions though. Should I start? Okay. How do you diagnose the patient has LPRD?
The patients that we have taken the patients were most, they can talk, they can read and speak English and Bangla, both. So we have diagnosed with the English questionnaire where the score was greater than 13. That means they have LPRD. Along with that, we have also correlated with the reports of the other gastroenterologists.
And laryngologists.
Yes.
So you think an SLP cannot diagnose LPRD?
Yes, sir, they can do that. But for the reliability, we have checked both so that the tool is, whether the tool is reliable or not, we have to make it sure.
So from the SLP point of view, you're saying a SLP can diagnose from this tool rather than doing an invasive
This
process.
is a perceptual tool, sir, that is been used by the patients. It's a patient-driven tool. More tests to be done, but this is the tool that we can use primarily to understand whether the patient has LPRD or not. So this is a patient-driven tool.
And why do you think a patient comes to a doctor having LPRD? With what complaints?
To a doctor, sir?
Or anyone, like with what complaints does a patient come?
So there is some feeling in the throat, like the lump in the throat, or there is a sore throat. There can be some kind of voice problem.
That's what I was asked. Inclusive in your inclusion criteria, have taken patients having no voice problems on Grabber scale, right?
Yes, sir.
This was your inclusion criteria where Grabber scale has no voice problem. But do you think that any LPRD patient would not have voice problem? It's very
So
common with LPRD to have a voice problem, more common than dysphagia. That is what I feel.
So there can be
So
voice.
if you have included voice patient, what would have been difficult? Like if the patient would have complained with voice problems also, would it jeopardize your study?
Sir, at first, as we were doing this was a
Want to take exclusive LPRD patients only?
exactly, that was the main thing. That's we were focusing on that only, so we were not seeing the other problems, so we have excluded that part for now.
Associated problems are always there. Like
Yes, sir.
a person with a CKD will have any associated problem. You cannot chalk out the other symptoms or other comorbidities. Lastly, I want to ask you is, can you show me the tool?
Yes, sir, sure.
This is the Bengali one.
Yes, sir.
So this tool is not for illiterates. Person who cannot read Bengali would not be able to do it.
So if then it will be not only a test that will be done by the patients, then somebody else has to help her for that.
And can you show me reference where you find that this LPRD patients has heartburn problem or symptoms of heartburn? Like for differentially diagnosis GERD from LPRD, a GERD patient would actually complain of a heartburn rather than a LPRD patient who has more symptoms in his larynx and
In larynx and pharynx.
irritation. So I'm asking in that way.
So if we are talking about the references, so there are studies by Lichen et al. There are a number of studies by him that says that have differentiated LPRD from GRD.
Okay. And why do you think your first sentence in your presentation, go back to introduction.
Okay.
You say like, yes. A large population who speaks Bangla has growing risk of LPRD. Why do you think that Bengali speaking people have got more LPRD?
So Bengalis are big foodies, so.
So if you are foodie, you should not have LPRD. LPRD is
So
mainly
they
you
don't-
give gaps in between foods.
So there is both the problems. They are foodies, so at the same time, they also have these problems. These are very related with Bengalis, I guess.
So any studies related to that you have a reference?
Okay, nice presentation. Can we go to the exclusion inclusion criteria? Do you think anxiety and LPRD are related?
So in some cases, it can be.
You have not excluded that. BMI index is a matter with LPRD?
Yes,
Do you
sir.
know?
So sorry, I can't.
BMI,
So that can be.
not excluded. So the bias factors are there in the study as per me. Whenever you're excluding factors, and those things has to be done. This study has been done where?
So we have taken patients from our own college as well as from different medical colleges and hospitals around the college.
So how much time you have taken?
So 3 months.
60
So
participants.
30 participants with LPR and 30 participants without LPR. So 30.
But first, the study has been done without any pre-diagnosis.
No, sir. Those were diagnosed patients, but we have divided it into 2 groups. 60 participants, 30 with LPRD and 30 without LPRD.
LPRD has been confirmed later on by gastroenterologist or
So
laryngologist.
they were previously diagnosed and we have verified.
That means already you know they have a LPRD.
Yes,
and then
sir.
you do the study.
For the reliability of the study, sir.
No. First thing is
Yeah.
that if you already know a laryngologist or gastroenterologist has already been diagnosed LPRD and you are applying these scales, then there is a bias factor. Should not.
Sir, for the reliability of the test.
Reliability validity should be first you've done the test and then you send it to all the patient to the LPRD for diagnosis. You have done the diagnosis, first you've done the objective, first you've done the BERA, then you do the PTA. Then what is the validity of PTA? You've already seen ABR is already showing the thresholds are normal. Then you are again doing the PTA.
So, as it was done by the patient itself, but we are not doing it. So,
No, question is very clear.
so
If
yes,
the diagnosis has already been done and established, then the question is a bias factor. It's just a study. It's just numbers. Do you agree? Thank you.
Thank you, sir.
Sonal ma'am, would you like to ask a question, ma'am?
Yes, very good clinical implication it will have because SLP is entering into reflux measuring is itself is nice. I would like to ask you, did you come across false negative scores among elderly in your study?
Ma'am, could you repeat the question, ma'am?
Did you come across false positive and false negative scores, especially from elderly population? So which were more, and did you work on those scores while making your psychometrics of your tool validation?
Ma'am, if I'm talking about each item response, then we have not assessed that till date. The item responses are not taken into account for this study. We have not done that. So we haven't done a specific study on that.
That should be something helpful for you, because when you're seeing
Yes,
inter
that,
item and item to item, it will be changing, because the reflux is a vague symptomatic in some people. Sometimes it could be post the person has just got up from the sleep. Sometimes someone has eaten and done some exercises. So this could be somewhere what you can control in younger population, middle age, obese, not obese, very thin, very anorexic, or the elderly population. But a good attempt. Thank you.
ma'am. Thank you, ma'am.
Can we have next presentation?
Thank you. Here comes our third contestant, Harish Murali.
Good afternoon. Greetings to me. So myself Harish. Today I'm presenting the following problems in individuals with Parkinson's disease, a self-perception study. So introduction. So Parkinson's is a neurodegenerative disease that occurs the loss of neurons in the dopaminic and in the neurons in the substance nigra in the pars compacta. It causes the tremors, rigidity, bradykinesia, and dysphagia in the postural instability also. So the prevalence of PD to be have 45.82 per 1 lakhs. This et al. Das et al. 2006 will be given in the Indian study. The prevalence of oral pharyngeal dysphagia in PD range from 18.5% to 100%. So dysphagia often noticed in the 80% of patients with Parkinson's disease. In advanced stage, it will be the 100%. So patient report outcomes. It is an important outcomes of the clinical evaluation for the wide range of health issues, including the following. It considered has been important step 2 before initiating the medical evaluations. So we have the provides information of holistic clinical markers and quality of life. So these are the some basics of the dysphagia questionnaires. So I preferring the Signis following questionnaires. The Signis following questionnaire is a severity check of oral pharyngeal dysphagia. It consists of 17 questions that assess the severity of oral pharyngeal dysphagia. So using the cut 233 out of 1700 was indicative of the oral pharyngeal dysphagia. So the need of the study, individuals with Parkinson's disease often find it difficult to visit the hospital in person because of the motor or movement issues. So PRO will help the professional to get an idea of their solving difficulties. Looking at the rating, further evaluation can be suggested. If not, management can be advised and carried out. It was especially helpful during the COVID scenario. So this leads to be the current study. My aim of my study to profiling the following difficulties reported in the individuals with Parkinson's disease and neurotypically elderly populations. The objective of my study to prevalence of following difficulties in PD and neurotypical elderly populations. So the perform the age comparison between the Parkinson's disease and neurotypical elderly populations. So the method, the 60% participation will be participate in my study. So 30 will be the neurotypical and 30 will be the Parkinson's disease. So the inclusion criteria will be the above the age of 60, the no severe cognitive decline score of 20 and above from the MOCA. So also on the Provincial, the exclusion criteria. So individuals with any other associated neurological conditions. So the procedure will conduct on the online mode. So the first phase will be the informed consent will be sent through WhatsApp and email along with the questionnaire. So MOCA cognitive examination will be applied on the software basis because it's an online mode. So I building with the software of 3 tasks for visual, spatial, and the naming skills. And also the phase 3, the Signis online question admin for both PD and NT. So these are the results. So PD had a presence of dysphagia out of 30 is 25 is presence, but in the presence of a neonatal typically it's have 5. So the prevalence of PD has 33% and the NT has 13%. So the PD has the difficulties in majorly thick liquids that like soups, milkshakes like that, hard foods like raw vegetables, raw fruits, like coughing and choking along with the feeling of food getting stuck in the throat, extended mealtime duration of 45 minutes to 1 hour in the Parkinson disease. But in the neurotypical cases, the concern of the dry fruits like biscuits, breads, and nuts and all had difficulties. Hard foods along with the food feelings of food getting stuck in the mouth also. So they also reported in the swallowing the first bolus of the day along with the tingling sensations for the neurotypical elderly populations. So the mean and standard deviation for each questionnaire will be the first, the Parkinson's had the issues in the all the range of 17 questions, but the neurotypical had only have hard foods, mealtime, severity, and the quality of life only compared between the neurotypical and the Parkinson's disease. So the objective, second objective will the age match comparisons. The raw score of individual with PD and NT. In the participation of 60, the PD and neonatal had not have the no swallowing problem. But in 62, the PD had severe swallowing difficulty in oropharyngeal dysphagia, but neurotypical habit did not have any swallowing issues. So crossing to age of 60 to 78, there is a no swallowing difficulty in the elderly population, but we have 79 and 80, we have mostly severe to moderate to severe problem in the swallowing difficulty of both PD and neurotypical typical. So the age match comparison between the pediatric and Parkinson disease and neonatal. So 60 to 70, there's a no swallowing difficulties. 69 to 75 years of mild to moderate swallowing in PD. In neurotypical, there's a no swallowing difficulty. 69 to 76, we have moderate to severe, but in neurotypical, no swallowing difficulties. But in this case of 79 and 80 years, there is a severe swallowing difficulties in both disease. So the discussion, the prevalence of swallowing problem in the current study was 83% in PD and NT. So the prevalence of dysphagia was 18.5% on to 100% given by Lucy et al. 2017. So the age comparison data identified the presence of swallowing difficulties in PD and neuroelderly populations. So that swallowing difficulty were because of the neural degeneration in pediatric Parkinson's disease, reduced wateric swallow of control, and the presence of alpha synuclein under the atrophic the oral preparatory and oral phase of swallowing. So the neurotypical had the poor dentition, reduced the lingual sleep, delayed swallow trigger, and inadequate laryngeal evaluation. So any individual's mealtime duration is considered to be an important part of swallowing efficiency. Also the functional outshare rules are really helpful for the professional to understand the extent and nature of the problem, which helps in the clinical decision making for further assessment and management based on the patient response outcome. Its study gave a clear definition of the swallowing problems in individuals PD and neonatal geriatrics, which also made the Parkinson disease group to understand the seriousness of the swallowing problem and to keep them motivated for management of swallowing problem. And with individuals with the PD is reported to the poor social awareness, self-awareness of their difficulties. But in this my study, the pediatric population had a greater awareness during my swallowing abilities. So these are my references. Thank you.
Presentation. There are a few questions which I'd like to ask. First of all, the questionnaire was in which language?
Sorry, sir.
The questionnaire, self-questionnaire was
English.
in English. So they were all able to understand.
Yes,
that?
yes.
And who assisted to understand the questions?
The self-questionnaire, sir. So they only read and they only monitor.
There is no no one.
No one.
Okay. Second thing, like you go back to the age matched changes back. Yes. Next one. Yeah. Like mostly you say 5 to 100% of dysphagia present in those populations. Advance how the disease advances. You get from 5 to 100% of dysphagia.
In advanced stage of Parkinson's, sir.
No, Like 18.5 is also in advanced,
No,
100 is also in advanced, or is across the population, like with the change of age.
Like across the advantage of stages, advanced stage will be the Parkinson. So the swallowing. will be-
100%.
Yeah, sir.
So it increases along with the age increases.
Yes,
Or the
age
Parkinson
increases.
progresses.
Yes, yes, prognosis.
So 60, 68, 70, this years you had no swallowing difficulty.
In my study, there is a no swallowing difficulty.
Yeah,
sir.
but it would have been you trying to increase the awareness to the patient who has got like many PD patients would report only through a questionnaire. If you have done an instrumental as would have find those patients may have.
This is my future study to correlate the subjective and instrumental study in the.
Yeah,
future.
but will you include these patients in your study also?
Yes,
This
sir, yes, sir.
60, 68, 70?
No.
Because so I'm telling you should include this also,
Okay, okay.
where you have not found any difficulty in swallowing. In instrumental, they might show that they have full vallicula, which the patient might not even understand.
Okay.
They might have a secondary aspiration, which can cause them this pneumonitis.
Pneumonitis.
So don't exclude those patients.
Yes.
So, and also correlate with the evaluation to tell that even this patient on the questionnaire, no swallowing difficulty may end up having dysphagia or sand aspirations or secondary aspirations when they sleep.
Nice present. So onset of the disease is important or the age?
Sorry.
Onset of the disease is important. The duration of the disease is important or the age?
Age.
How come? If somebody has early onset of Parkinsonism 5 and he comes to at the age of 70, so the lifespan be 15 years. It cannot be severe.
Severe, yes, sir. Severe.
Cannot be severe. So you missed what as per me, you missed the single parameter, the onset of the disease.
Okay, sir. Okay, okay.
Because onset can be at 71. Yes, even I have seen patients early at 45, 46 also. So onset has been missed. That you have done an online questionnaire and the patient they themselves has answered the questions. So that means a severe Parkinsonism patient has a and cognitive skills who can on online. Do you agree?
Yes, sir.
After my questions, a severe Parkinsonism patient means bed treated in advanced stage. They themselves can answer questions online.
No.
But you are showing that.
So there are English professions, but they do it fun studies.
No, you told that they themselves have answers, and already they are in the advanced stage. So those are contraindicator.
Okay.
He has done MOCA. You will tell not the cognitive. So that means what I feel is a fabricated.
Okay, sir.
Do you agree?
Yes, sir. Okay.
It is fabricated. Nice presentation. Thank you.
It's very nice study, has a lot of clinical relevance to your clinical.
Sonal ma'am.
Yeah, can you hear
So,
me?
Sonal ma'am, do you have a question?
Yeah, I have a question to the presenter. Am I audible?
Yes, ma'am.
Yeah, so a very relevant study clinically, because we get to see a lot of movement disorder studies. So you need to really understand the duration. My fellow co-chair has really raised a very important concern, but not only just onset, but bulbar or spinal onset, because bulbar onset PDs will have early speech and swallowing deficits. There could be some 10 years of standing PD, but no significant dysphagia reported. So you need to really consider this as being SLP. And also Parkinson's and Parkinson's plus syndromes. You haven't mentioned any of them, if they had any of PSP component, or what were the Parkinson's disease spectrum. And motor cognition, it's very important that you need to really see that action tremors and the resting tremors. Earlier, people only would know that, okay, the person is having Parkinson's, and then SLPs will come and profile the swallowing and speech symptom. But world has gone ahead. you need to really understand the motor cognitive markers also. So
Okay.
check the important scales. See the UPDRS, if you can get the important aspects about speed, swallowing, presence of dysarthria, mixed component or typical hypokinetic. It has to be mentioned when you are profiling swallowing, because they go hand in hand with the comorbidities and affecting your oromotor importantly for manifestation of early preparatory phase, which I found that was not greatly mentioned. And it may not be a prevalent study alone because it's a single state center study, right?
Yes, sir.
And that too, it has not been controlled well. So in what state, what city, how many days, how many months, and may not be prevalent, but in the occurrence study, what you could label it as, might be you can work on, because many of researchers into digitology are really ambitious, but they need to really work that, can we say the percentage that yes, 18%, it might be more than that, because the population what you have got might not have been picked up well. So do understand while you're working on your titles, but it's a good study, you can take it ahead. Thank you.
Okay. Thank you, ma'am.
Thank you. Judges, please note, presenter 4 is not reported, hence it remains cancelled. Kindly note, presenter 4 is not reported, hence the presentation is cancelled. So next I call upon presenter 5, Dr. Preeti Shetty A. Presenter 5, Dr. Preeti Shetty A.
Hello, everyone. A very good afternoon. Topic of my research is translation and validation of MD Anderson dysphagia inventory in Kannada. We human beings link the eating and drinking to the human pleasure. Dysphagia makes it laborious and uncomfortable. Sorry. There are several consequences of dysphagia, medical as well as psychosocial consequences. Dysphagia is complex and multi-layered. It impacts a person in terms of physical, emotional, social life, and it also burdens the family members. Specifically, individuals' functioning and quality of life is affected. The focus of today's presentation is quality of life. World Health Organization defines quality of life as individual's perspective of life in the context of culture and the system he lives. If you see, International Classification of Functioning, Disability and Health. Dysphagia not only affects the structure and body structure and function, it also affects the activation and participation. Hence, quality of life is affected. There are several indicators for quality of life. It includes physical, cognitive, employment, freedom, social, recreational, and leisure, mental health and emotional, and religious beliefs. Negative impact affects the quality of life. It can impact immediately after disorder or months later or years later. So if you see, most of the common cause of dysphagia we have today is head and neck cancers. 90% of them are epithelial cell malignancies. If you see the picture of pathophysiology, you see the epithelium getting affected from normal to hyperplasia to the severe carcinogenic cells that are there. The need of the study was head and neck cancer affects social well-being because of dysphagia. Other disorders because of dysphagia also affects the social well-being and quality of life. Hence, a vernacular version of MDADI, that is in Kannada, was warranted because getting the information about what are the indicators for quality of life would be important for assessment as well as management of the patient. MDADI is a self-administered questionnaire designed specifically for evaluating impact of dysphagia on quality of life in patients with head and neck cancer. It is a 5-point rating scale, has 20 points, which assesses global, emotional, functional, and physical aspects. The objective of the study was to translate the MDADI in Kannada and to estimate the test-retest reliability and internal consistency of MDADI, to validate the translated scale to standard dysphagia measure that is there. A total of 57 participants were recruited cross-sectionally from HCG Center Hospital, Bangalore. Before the initiation of the study, permission from the original author was obtained and phase 1 was initiated. Forward translation, synthesis, backward translation, review, cognitive debriefing, and consensus were taken for translating and validating this study. Next is phase 2, that is validation of MDADI. After informed consents, patients were recruited who satisfied this inclusion criteria, which is as follows: who is more than 30 years, both male and females, who is diagnosed as head and neck cancers by oncologist, diagnosed as oral and pharyngeal dysphagia, and formal education of more than 7th standard. Whoever satisfied the criteria were included. They underwent detailed case history, dysphagia handicap index, EAT assessment tool, functional oral intake scale, MD Anderson dysphagia inventory in Kannada, and video fluoroscopy, specifically penetration aspiration scale. Statistical evaluation was done after the data was coded, loaded, and assessed in SPSS version 21. Statistics of descriptive statistics was done to get the group characteristics of the patients who were recruited. Conbac alpha was done to evaluate objective 2. Spearman's rule was done for the objective 3. The results shows that the mean age of the patients were 55.96 years. Both male and females were recruited. Majority of them had oral cancer and TNM staging was about 2. The majority of the symptoms that they reported were weight loss, long time to eat, and problems with liquid. Majority of them were surgically, surgical resection was done for the head and neck cancers that was there, and they were on oral and PEG tube majoritarily. The result shows that the patient had, the overall scale had Conbac alpha of more than 0.9, which shows excellent test-retest reliability, and Conbac alpha of more than 0.8 was seen for showing good internal consistency. Validation of MDADI was done and correlation was done, which showed that there was positive significant correlation between MDADI-K and FOIS scale and PAS. It means as the scores of MDADI increased, PAS and FOIS levels also increased. And There was negative significant correlation between MDADI and E10, DHI10, okay, and all the other domains of DHIs. So the finding of the current study indicates that MDADI-K is a valid and reliable tool which assesses the quality of life in patients with dysphagia secondary to head and neck cancer. The findings of this study is in line with all the other versions which are there in English, Italian, Brazil, Korean, Japanese, Danish, Spanish, French, Indonesian, and Arabic. And this is the first Indian vernacular language study. So our future direction is in adjunct to all the clinical evaluation, objective evaluation, and patient perspective rating scale that's there. Quality of life is also important, which gives us or includes the ICF model of activity and participation. These are, okay, thank you.
Very good presentation. So you have taken all the subjects. Minimum education is class 7 standard.
Yes, yes, sir.
Why?
Since it is self-administered scale, they should be able to read the translated Kannada version of MDADI. That's right.
Okay, so when the MDD has been developed, they also follow the same education parameters?
I didn't get you, sir.
When the MDI was developed in other places, would they follow the same criteria?
No, sir, but since it is self-administered scale, we should make sure that they understand the instruction that's written and they should take rather than changing the words that
So
are there.
do you have, it's just a query. Do you correlation between the educations and the efficacy of answering questionnaire? Any correlations have you got like any false positive or false negative? Have you got any responses?
For the current study, that was taken as just an indicator for inclusion in the study. We have not done any correlation, but however, if example, there are two ways of administering the scale. Either you ask them to read do you feel? Because we tend to tell, is it 0 or is it 5? Can you tell me quickly? Means we tend to go quickly because we are aware of the scale,
Absolutely.
but they should take time. They should understand what is the question. They have to come back with whatever emotions in terms of all the scales that's there. That's important, I think.
Correct. Basically, it has been seen in many cancer studies. So somehow the counseling is a big part in the treatment part, and the candidate or the patient is more educated easily. He's more able to make him understand, okay, these are the outcomes is going to happen. If the level of education is less, on that case, the questionnaires, okay, definitely it is validated. I'm not asking any validation questions, but the chances of having false positive is very high. So that is the only input from my side.
Yes, sir. So only thing is what I would like to clarify is sometimes what we ask is, do you think so it is mild? Do you think so it is moderate? Do you think so? They tend to pick up with our emotion or the body language that we are there. Sometimes if we ask yes, yes, they'll say yes. So that's the reason they should take back and understand that.
Point is absolutely noted, but if we can add on the chances of having false positive or false negative correlation, it will be better.
Yeah, since the objective was this, we didn't try it. With your suggestion, probably we can try out and see what is the outcome of.
Thank you. Thank you.
Thank you.
Thank you. Thank you.
Sonal ma'am, you want to add up something?
Just a quick question. Preeti, a very good study, and validating this important outcome measurement scales, importantly qualitative measures, are very important in Indian languages. And you have taken a good step for the oncomechanical population. I wanted to ask
Excuse
you.
me, ma'am. Could you repeat the question, ma'am? It is not clear.
I'm so sorry. Now, can you hear me? Is it clear? Hello?
Ma'am, could you be a little more louder?
Yeah. So what was the main why
Thank you for the question. MDADI was developed by MDADI Center, which is specifically for head and neck cancer. They say that it is specifically for head and neck cancer. That's why we didn't go to since it's not developed here. We didn't go to try it with neurological patients. But in future, definitely we can try asking the same question, because it doesn't ask anything related to cancer as such. It asks about quality of life. Definitely, we can try out validating on neurological patients.
And the quick second question is that, did you check Okay, good. Thank you.
Thank you.
Thank you, Dr. Preeti. Here we move on to the sixth presentation. Presenter Janvi.
Hello.
A very warm good afternoon to everyone present here. The topic of my study is a comparative study on the effect of age-related changes in swallowing. And the authors are Ms. Suprita Santosh, Dr. B.S. Premlata, and myself, Janvi. Now, before I move on to talking about the study, I just want to give a quick introduction to what a geriatric syndrome is. Yeah. So the European Council defines the geriatric syndrome as a clinical condition in older people that do not fit into the disease category, but are highly prevalent in older age. They are multifactorial and are associated with comorbidities and have a poorer outcome overall. And there are four main geriatric giants. The first one being immobility, instability, incontinence, and intellectual impairments. And now in 2000, they modified it into, and they added sarcopenia and frailty as another extra symptom. And in 2022, it was proposed by the European Council that oropharyngeal dysphagia specifically has to be involved as a geriatric giant, because it has been seen in more than 60, the percentage being 60 to 80% of the older generation have dysphagia. Although the severity changes, they always have oropharyngeal dysphagia as a symptom present. And that is still being under consideration. Now, these changes that are seen in the geriatric population can be due to many reasons, but the most common reasons being alteration in sensory perception, decreased muscle strength, neurological and respiratory changes. And these age-related changes of swallowing can affect either the entire mechanism or it can affect the individual deglutition phases. Now, as seen in the above studies, senescent changes have an effect on swallowing. And as an SLP, separating the effects of normal aging on swallowing from disordered population presents as a challenge.
So speech language pathologists need to become more aware of the swallowing mechanism in healthy older adults and should be able to distinguish between these two changes. And simultaneously, there's a lack of questionnaire that differentiate age-related changes specifically from a disordered swallow. And the aim of the study was to assess the swallowing abilities in geriatric population and compare it with younger cohorts to determine the changes in the swallowing abilities across different age groups. Although there are questionnaires available to assess the swallowing abilities and the quality of life associated with swallowing disorders, they are mainly focused on on either the swallowing function or mainly on the disordered population. Hence, a questionnaire was developed using MDA-DI and swallowing QOL as a survey as reference to assess the swallowing abilities in healthy geriatric population. It consisted of two main sections, namely the general and the demographic questions, which covered the demographic details of the participants and the functional and the emotional consequences of the swallowing problems. The phase-wise questions, meanwhile, consisted of the questions that were formulated based on the three phases of swallowing, that is the oral preparatory, oral, and the pharyngeal phase. Content validation was done by experienced professionals who were experts in the field of swallowing, and the face validity of the questionnaire was also done. Okay. The study included 113 individuals who were divided into three main groups, being 40 to 60, 60 to 80, and 80 to 100 years of age. And they were recruited based on the following criteria: that they were within the specific age group and they had no cognitive impairment. The informed consent was obtained of the participants after the procedure was explained to them. Then demographic details like name, age, gender, medical history, and comorbid conditions were obtained. A quick OPME screening was done, following which the MMSE was performed on them to check for their cognitive status. Following, if they passed the criteria, the questionnaire was administered on them. A 3-point rating scale was used for the scoring, and the scorings were divided into two main sections, being the general and then the phase-wise questions. The obtained data was then subjected to statistical analysis. Now, moving on to the results. The study consisted of 113 individuals, out of which 61 were female and 52 were male. In looking at the first section, that is the general question specifically, which looked at the psychosocial impact of the swallowing, 22% of the participants complained of swallowing difficulty. Dietary changes were made due to the swallowing difficulty by 15% of the participants, and 15.9% of the participants reported of losing appetite for the foods that they would enjoy, and they also reported having a prolonged meal time. Now, looking at the oral preparatory phase, the participants complained of having chewing difficulty, dryness of mouth, having the food stuck in the mouth after swallowing, and anterior spillage was occasionally reported. I would like to specify that the older of the cohorts consistently performed poorer, and it is being seen in this graph, wherein the higher the graph, which means the better are the scores. And then it is consistently being seen that the 80 to 100-year-old cohort has poorer scores, followed by the 60 to 80-year-old and the 40 to 60-year-olds. With respect to the oral phase, participants reported having difficulty initiating the swallow and had to vary the food consistency. And with regard to specific consistencies, individuals reported having maximum difficulties with liquids, followed by solids and then semi-solids. And here is the graphical representation of the comparison between the cohorts again. wherein once again, the oldest of the age range have the poorest of the scores. And in respect to the pharyngeal phase, the presence of throat clearance was reported by 26% of the participants and 12.4% of the participants as always. 30% of the participants had cough post swallow and 9.7% had cough during the swallow. And the following graph once again represents the comparison between the age ranges. Now, just to summarize my slides, there is generally increased anxiety in the older age range. And the 80 to 100-year-old age group showed maximum of the swallowing difficulty, pharyngeal phase being the most affected phase, followed to pharyngeal phase.
You. Sonal ma'am, do you want to start?
Yeah, a very important study you are doing on a presbyophagia. So I must congratulate your team. I had some concern. You said no cognitive impairment. You know, post 65, the age-related memory and cognitive impairment starts very evidently. And in your cohort, you have taken extremely fragile 80 to 100 who scored normal on your test, you said?
Yes, ma'am. Actually, when we did the testing, when we performed MMSE, all of them had higher scores available. And also the questions that we were administering were very simple and in simple English. So it wasn't when we first administered, all of them passed MMSE, and it has also been shown that MMSE comparatively to the other cognitive tests is a little bit easier for the participants to perform. So that is why MMSE was chosen
However,
when compared.
I'm not sure about the how correct that was like even administered, because above 85 to 100 you had got the participants who were really good to test and good to do on your cognitive test, but they were not doing good on the swallowing, what you have shown there. So there was some discrepancy, what I'm not still okay with that. But can I ask you that, did you check for motility disorders? Did you control for achalasia or ring, and how did you control the esophageal, pharyngeal rigidity in above 60 population?
Yes, ma'am. In the exclusion criteria, all the participants had no other disorders, like if they had neurological or cerebrovascular disorders or any other motility disorders, they weren't included in the study. And
About 80, did you try getting a VFSS, or how did you just take into consideration that they don't have any cerebrovascular changes or motility disorder?
it was based on the patient reports and as well as the caregivers, ma'am.
Mhm. Okay, Bhaskar?
Yeah, ma'am. So I also wanted to ask in this inclusion-exclusion criteria only that that whether do you consider any other comorbidities along with the patient?
Sorry, sir.
Any other comorbidities?
No, sir, no other comorbidities. were
All the
there.
comorbidities were like any other comorbidities was excluded.
No, sir. These participants had no other comorbidities. They were healthy geriatric population and they had nothing else. Medically, they were healthy. And the only symptoms they had was associated with aging. So there was nothing, they had no stroke, they had no significant motility disorders. Structurally, everything was fine. So
Did you check for other organs for the exclusion criteria? I'm not seeing a patient do not have COPD or CKD
And-
or.
And even if they reported any difficulty, it was a very fleeting. So maybe few of them complained of a cold that they had sometimes, but nothing significant of the sort, sir.
And how was the what is the number of 80 to 100 years, like the number of participants?
36.
Very difficult to find. Good.
Nice presentation.
Thank you, sir.
First question is that how this impaired visual acuity is related to dysphagia? And
Sir,
impaired means how much impairment? Like what I
uh,
personally feel, as you told, 80 to 100, you have 36 candidates. So above 80, definitely all of have some sort of visual acuity
Hmm.
problems. So above 80 and above 90, somebody don't have any specs.
Hmm.
So it's really tough to believe.
By visual acuity, sir, I meant something higher order. So if
What is the
specs-
definition?
So if they are wearing spectacles and they're able to visualize the questionnaire, then it was fine.
That means
Spectacles
they are
were
not
fine.
impaired. They don't have any impaired visual acuity.
Yes, sir. They don't have any. No, they do have visual affected visual acuity, but with
Should say
specs. they are fine.
corrected vision.
Yeah,
So
corrected vision.
vision. Okay,
Huh.
fine. So above 65, 70 degenerative disorder, you are saying brain atrophy is very common.
Yes, sir.
Have you done any MRI study or anything? Do you have? Like
Uh,
you are saying, no degenerative disease, I trust it. But
Hmm.
do you have any support to it?
So as of now, we asked for the recent screening when they went for medical checkups, and all of them reported to be healthy, and none of them had any symptoms of any other correlating disorder.
That means all these participants has no brain atrophy.
I mean, in aging, there will be atrophy, but nothing clinic, like nothing in the in the medical history.
Tough to believe. Now go to the questionnaire. So first questionnaire. Do you have,
Not
what
so
is the
one-
first question?
So 1 second. Do you which
Some,
one?
there is a questions. Do you have any chewing difficulty?
Where's this one, sir?
Some, there is a questions about chewing food.
Hmm.
So all of, I think above 80,
Mm.
they are using false tooth.
Identity. Yes, sir.
And all of them are happy with their false tooth.
No, sir, they weren't happy. That is why the
So
scores
that
became
means
less.
the
Huh.
chewing difficulty is because of the tooth
Hmm.
or oropharyngeal structures.
So
Or
uh,
all of them are using the false teeth or not.
so
Or
the-
if yes, how many?
Hmm.
If not, how many? And what is the correlation? And how this questionnaire, how many questions you have in the questionnaire?
so 113, sir.
So these questions has an input of 1 to 2% of the score. The scores can be affected by this.
Yes, sir. So we just wanted to see how edentulous is a very significant condition wherein chewing will be affected. So with respect to that, we also asked if they are using false teeth, did they help? And because of that, they had to vary the consistency of the food. So after that, there's another question there. So if you change, if you increase the, I mean, if you do you change the consistency because of that, then even that scores would affect. So overall, we are just seeing what all phases, if the phases are affected, what is affected more. And then if this questionnaire, it did show that there is significant impairment present in all of the 3 phases.
Okay, that's all. Thank you.
Okay, sir. Thank you.
Good presentation. I have a suggestion that what you can do it is take only 60 to 100 and see each 5 years grouping and see what are the major across oral, pharyngeal, esophageal stage-wise complaints they have with poor dentition, poor cognition. And it's very important that we consider motoric cognition. It's not just alone MMSE or MoCA, but the mobility, their verbal praxis, their verbal DDK, and their non-verbal praxis and non-verbal DDK. As SLP, I'm sure you are assessing that along with the swallowing praxis. That could be really helpful for you, that you can say that at what age actually you are seeing that there's a significant change, because they all are healthy. That means they have a good neural reserve if they have not picked up on the MMSE. However, you need to see that cognitive reserve needs to be somewhere mentioned, because above 80, above 90, and still not significant memory, attention, executive function impairment. That's something remarkable. You have got it. But that could be helpful if you please look into your data, relook into data, see the findings and see the 30, 35 plus and the group them and do the regression analysis factor wise. That could be great study, because we don't have Indian data. Are Indians with good cognitive reserve, with good physical reserve, also well preserved on swallowing abilities or not? That could be a research question. All the best.
Thank you, ma'am.
Thank you, Ms. Janvi. Next, can we have Ms. Cheryl George, presenter 7 on stage?
Hello all, good afternoon. So myself Cheryl George. I just Good afternoon all. Myself Cheryl George. So the topic is going to be the indications for gastrostomy feeding in young children with oropharyngeal dysphagia, a retrospective case control study. So this study was done under the guidance of Dr. Jayanti Pavitran. Moving on to the introduction. Sorry. Moving on to the introduction, ability to feed is one of the earliest and the most essential complex behavior to be developed. The anatomic structures and physiology of swallowing mechanism is different among infants, young children, and adults. So dysphagia can occur in any of 3 phases. The pediatric assessment and management includes the bedside screening, OPME, and a clinical evaluation, followed with an instrumental evaluation of VFSs and fees. So the management for the pediatric dysphagia is carried out by a deglutologist or a SLP, which is a non-surgical management where it requires a postural modification, consistency modification, combined approaches, nutrition monitoring, NGT, and peg care counseling. So the background for the study, there is a lack of clarity in the selection of the pediatric patients with oropharyngeal dysphagia for a long-term tube feeding. This may lead to the unnecessary delay in instituting the right feeding method for children in need and adequate nutritional supply for the support. Necessity for the gastrostomy. It is a safe, quick, and effective method. It helps to maintain an adequate nutrition. It is carried out for a long-term NGT and OGT feeds. PEG is normally carried out in a multidisciplinary team with a gastrologist, pediatrician, etc. Aims and objectives of the study to identify the clinical and the radiological characteristics of children who require tube feeds for more than 3 months compared to those who are off tube feeds completely. So the materials and methods which was included for the study is, it's a retrospective case control study with 141 pediatric patients with dysphagia. So the pediatric patients were split up into 2 groups, a study group of 71 and a control group of 70. So the data was corrected from October 2021 to July 2022. It was from an electronic database with institution permission. The inclusion criteria, pediatric patients with dysphagia who visited the Amrita Swallow Center during October 2021 to July 2022, age range of 0 to 15 years was included, and the patients who had a detailed reports and VFSs of the study was included. Exclusion criteria is pediatric cases who are under critical care unit, caretakers who are not willing for the detailed evaluation, pediatric cases who fail to follow up. Statistical analysis. So the statistical analysis was performed using an IBM SPS version 26.0. Mann-Whitney's use test and Pearson chi-square test was applied for comparing the proportion of indications in between the 2 study group and the control group. The p-value is less than 0.05 was considered to be a statistically significant. Results. So moving on to the demographic data. The female population was on a greater rate comparative to that of the male population, and few disorders which were prominent in the pediatric population was included in the study, such as syndrome, neurological disorders, congenital heart disease, seizures, neurosurgery, abnormal MRIs. So based on the variables, neurological disorder babies had a higher rate of alternative mode of feeding. That is, they required an alternative mode of feeding more than 3 months. So they were included in the study, comparative to that of the neurosurgery pediatric patients. So the study is mainly carried on two main variables. One is the clinical findings and the other one was the radiological findings. So the clinical variables was around 12 in number, in which the most significant clinical variables, that is both the indications from the control group and the study group was included. In that, the ones which are less than significant value of 0.05 who required a need for a prolonged tube feeding was included, where they are the failure to thrive, recurrent LRTI, poor secretion management, dysphagia for liquids, dysphagia for solids, clinical aspiration. So these were the significant clinical variables which was included. The radiological variables which was included was around 14, out of which the most significant one which required a prolonged tube feeding were penetration, aspiration, anterior spillage, lingual coordination, and pharyngeal coordination. So based on both the clinical findings, the significant final outcomes will be like the pharyngeal dysphagia, aspiration, and failure to thrive. These three were less than 0.005. So they are more significant and where they require an alternative mode of feeding, that is PEG feeds. Then compare oral dysphagia and esophageal dysphagia. While comparing to those, they were like that not significant. Like where oral dysphagia, it can be treated with compensatory manuals, and esophageal dysphagia, it can be carried out with anatomical surgeries and so on. So these are the significant findings. Moving on to the conclusion. Based on the clinical findings, failure to thrive, recurrent LRTI, tube feeding in infancy, tube feeding more than a month, was considered based on the clinical evaluation, like based on the clinical variables for good candidates for PEG insertion for more than in delay in swallow reflex and penetration by the statistically significant variables in VFSs. Limitation, it was a retrospective study. Patients belonging to various developmental ages, VFSs findings were scored by a single rater and no inter-rater analysis was done. And these are the references. Thank you.
Very good study. So after this study, what is the clinical outcome like in a gastrostomy tube team? Like with it basically what protocol we follow? If the PEG has to be done, it should be assessed by an SLP, and the SLP has to predict the prognosis.
Sorry, sir, I didn't get you. Sorry.
So if somebody is there in ICU or in say PICU, we should be done an SLP assessment. The prognosis has to be predicted by the SLP, and it's a joint, and even sometimes we involve a pulmonologist also, pediatric pulmonologist. So a patient has gone for 2 times or 3 times bronchoscopy, and the patient is aspirating again and again. So we make a team, and then finally we decide okay, we should go for gastrostomy. Here, who has taken the decisions to go for gastrostomy?
No, sir. It's like first the baby will be carried on by a multidisciplinary team where the baby is under pulmonologist, everyone, as you told. So we'll first the alternative mode of feeding of the baby will be an NGT or an OGT. So the baby will be like based on the condition. If there is a progress on a baby, we'll just manage with the compensatory techniques. We'll just carry on the management with postural modification, consistency modification, and all. If the baby requires a long term of management, like a long term of alternative mode of feeding, it's not like NGT, as we know, like the laryngeal structures as the baby is getting developed, it will be affecting the structures of the baby. So it's better to go for a PEG insertion.
Oh, I understood. My question is very clear. Prognosis part has been clearly that the prognosis can be very slow in nature. So you have to go for the PEG. So that will help the baby to gain weights and other factors will there, developmental age. My question is very clear. With all the patients, the therapeutic maneuver or the therapeutic management was documented or not? Like somebody has come to me, suppose I'm giving a case study. The case has been referred to me as a preterm baby, 32 weeks has referred to me at the age of after 2 days. And we start the management. And the management was, we do it very strongly every day, 2 times therapy, or we are asking the patient to come to the follow-up of the discharge. And then we finalized after 3 months of therapy, prognosis cannot be that much. And after 2 months also we can go. Now we should go for a gastrostomy. Whether in those cases that has been done properly, whether the management part has been taken care by the SLP, or sometimes the patient has been discharged, they have gone to go and they're out of therapy or something like that, and then they come back and go for gastrotomy in the follow-up sessions.
So it is completely a retrospective study. So it's like a study group and a control group. So control group people weren't involved in the study, and the study group people who already had a PEG insertion and the babies are now on PEG. So I'm not like, if we are doing in a prospective manner, we'll just
But
consider
there, the
about this.
management part is very important before going from gastrotomy.
Yes.
Like, this is, to be very honest with you, what I have seen in my practice, the doctor saves the life, we give the quality of life. So after the PEG also, the patients, if have a reflux disorder and the child, sometimes they vomit a lot after the feeding or something. So chances of aspiration is also there. So we mostly do fundoscopy in few cases. So here the team effort is very important. Like SLP should guide when to go and not to go. And after the PEG, the child is not out of the risk. Still he's at risk. So the treatment procedure should go on. Sometimes it has been seen, gastrotomy has been done and child is not coming for the therapy regularly. So that is the only input I should give. Otherwise, this is good study. Thank you.
Thank you, sir.
Sonal ma'am, you want to say something?
I must congratulate your team. That's something which is very helpful. The enteral feeding in children with oropharyngeal dysphagia is not much worked on. So it's a good study, good attempt. You must publish the results. I have this quick question to you.
Yeah,
I
ma'am.
work with neuropalliative care with epilepsy, the failure to thrive children, and the onco team, the neuro-onco. So have you, sorry, the disturbance. So So have you come across any parent, not you alone, but your team, that the parents were not giving consent for the enteral feed because of the concern that the child has to be fed through orally, or it was kind of adjusted? Because many patients, we get to see that parents are not happy with enteral feed and they don't want a tube feeding, despite of we warning them, we telling them that child